Dr. Drew Remignanti is a retired emergency physician with 40 years of experience who practiced through the foundational years of emergency medicine as a specialty. Having experienced healthcare from both sides as a physician and as a chronic autoimmune disease patient for over 50 years, he brings a unique dual perspective to understanding what's broken in our healthcare system. He holds an MPH in public health and has completed international public health projects in Pakistan and Ghana. He's the author of The Healing Connection, a partnership for your health, which represents his legacy work advocating for relationship-centered healthcare reform. Please share your work with us, Drew.
Okay, thank you, Dawn, for inviting me on and for that introduction. I wanted to highlight the fact that I come at this issue. My book is based on an effort to try to preserve the patient-physician relationship, and I come at it from both angles of being a lengthy career physician and also a lengthy career patient. Just add the highlight of my career or low point of my patient career was when I had a stroke. I was actually at the very end of an emergency department shift in my own hospital and single coverage. Unfortunately, the emergency department was empty of patients when my staff said to me I needed to take off my white coat and get on a stretcher because I was looking wrong to them. When I basically they noticed I had a left-sided hemiparesis and I was being a little bumbling in my speech and talk and my walking. And they later told me they tried to make it up to chalk it up to the fact that maybe I had a Bell's palsy and was sleepwalking. And so they were kind of in denial that it could be anything else. It turned out to be that I had clotted off my right middle cerebral artery at its origin. Because a couple of details, the right middle cerebral artery was a good choice because it didn't involve my left hemisphere, so there was no speech involvement for me, and there was no didn't affect my dominant right side. Anyway, without those additional deficits, I was able to eventually rehabilitate back into emergency medicine by 1997. I had a 5-year enforced hiatus in my career. And when I came back into emergency medicine after that 5-year hiatus, medicine had changed in a number of interrelated ways that had not definitely been a change for the better. Emergency medicine had changed for the better. We had rapid sequence intubation meds now. We didn't have to brutally intubate patients without sedating or paralyzing them. So that was nice. But the kind of things that changed in the interim, one of the very first things I noticed when I came back to emergency medicine was up there on the vital signs across the top of the sheet, there was this new number from 0 to 10, which was the patient's pain scale. I thought, well, that's kind of odd because all the other vital signs are very objective measurements. And here you have this very subjective measurement giving pride of place at the top of the sheet, along with the very objective vital signs. So that was surprising enough. But then it was even more distressing to learn that now that was like the most important vital sign for the administrative people, which was getting rid of people's pain. And when it was always important to us to control people's pain, but it was equally important to us to figure out why they were in pain, what the cause of it was, and what the best management of it should be. But from the administrator's point of view, they really just wanted a satisfied patient who might come back to the emergency department. So intense pressure was placed on us through things like patient satisfaction surveys, like the Press-Ganey score, trying to get the best Press-Ganey scores that the hospital could achieve through you. And I did have a nurse practitioner colleague tell me at one point it was implied to her that she should perhaps be more liberal with her use of narcotic pain medications with her patients so that she could improve her survey scores. And that was done in parallel with, at the very same time period, Purdue Pharma was promoting and marketing their OxyContin medicine as a narcotic pain medication that was very safe and not likely to lead to narcotic addiction. We all know how that ended up turning out. The thing that I found most appalling after returning to emergency medicine after 5 years was that the patient-physician relationship was being replaced by this consumer-provider model, which is what we're suffering under right now. Patient-physician relationship is rapidly being replaced by a consumer-provider model, which is both less effective and more expensive, I find. And that hallowed patient-physician relationship is well along the way of being completely replaced. So that's what motivated me to write my book, which is what I have to offer for what it's worth. The first phase of my chronic illness was ulcerative colitis, in which I had 15 hospitalizations and 7 different abdominal surgeries to deal with that. And the second stage was when I had this stroke, which was thought to be from the same exact autoimmune process. Now I'm in a third phase where it's the same autoimmune process is now attacking my liver. So I'm glad I got my book done before the liver disease has made me less alert than I normally am. At any rate, that's my ask, is for people to consider taking a look at it and giving my book a read. It's 300 pages with 280 references, because I felt it was important to try to get patients and physicians on the same page. As there's no way we're going to preserve the patient-physician relationship unless all hands are on deck trying to do it, include all healthcare workers and patients themselves. I found that healthcare workers, you can only make so much noise before you're fired as too squeaky wheel. Was Hospital administrators don't want to fire their patients, of course. So I think we need to enroll patients in this effort to try to improve the patient-physician relationship. Healthcare decision-making, of course, would be far easier if we were just simply mechanistic biomedical entities, but we're not. As George Engel explained in his biopsychosocial model, which came out as far back as 1977, we are a much more complex species than pure biomedical entities. And so the one thing that I did in my book, which I think readers can benefit from, is I have 280 plus references in my book, and I was able to find active links to 250 plus of those articles, so people can go to the original research that I found that supports the patient-physician relationship, not just as a nice sounding thing, but as a more functional thing, and can even actually cut our mortality rates in half if we pay attention to it. So it's not like it just benefits us as physicians, it benefits all of us as patients as well. I do want to just end on three good news highlights from the scientific studies that I did find. The first one was in the topic matter of adherence, which is a very low-tech, low-cost way to reduce our mortality rate risk by as much as 50%. You can cut your mortality rate in half by being a more adherent patient. And you become a more adherent patient by becoming more knowledgeable about and more engaged in the planning of how we're going to treat our healthcare. And when patients do that, they are subsequently more adherent with that plan. And here I'm going to, like I said, read some quotes from the studies that I came across that I found eye-opening and made it easy for me to proceed with the research for my book. Here's one. Poor adherers to treatment were 2.6 times more likely than good adherers to die within a year of follow-up. That's a conclusion of a classic gold standard randomized placebo-controlled double-blinded study with the use of beta blockers in the setting of the post-heart attack patient. So I came at the whole topic of writing my book with a skepticism, which we should all do when we read everything about anything regarding medicine. So I said, that just indicates that good treatment way works, right? You take your beta blocker in a post-MI setting, you're going to do better than people who don't take it. However, this was the interesting thing. The same findings were present whether you were in the placebo category or the propranolol category. The study authors write, poor adherers to placebo were 2.5 times more likely than good adherers to die within a year of follow-up. So it didn't matter whether you were taking a placebo or the beta blocker in terms of the success you achieved. Simply adhering to a treatment plan reduces mortality. In the book, I go in a little more depth into things like healthy adherer effect and placebo effect, which may be contributing to that surprising finding. The second category of studies I came across were what I refer to as connectedness studies. And these are quotes from the conclusions of these studies. Individuals with adequate social relationships have a 50% greater likelihood of survival compared to those with poor or insufficient social relationships. In fact, the most isolated group of men had a mortality rate 2.3 times higher than men with the most social connections. While for women, it was even more impressive. The more isolated women had 2.8 times higher mortality rates than women with more social connections. And again, as a skeptical emergency doc, wasn't unusual for us in the ED to have a patient come in because someone went to check on them and found them at the bottom of a set of steps where they had slipped during the night and fallen and either fractured their hip or somehow incapacitated themselves. And then they were lying on the floor in their home for sometimes hours on end, the poor souls. And then they developed rhabdomyolysis and kidney failure. So it made perfect sense to me that that's just friends checking in on you, isn't it? So if you have more friends, you have more friends likely to check in on you and find you. However, what the authors of these studies find when they look more carefully at all the data, there's essentially no difference between objective and subjective measures of social isolation when predicting mortality. In other words, simply feeling less lonely and feeling less isolated reduces our mortality, consistent with George Engel's biopsychosocial model of what we are as a species. And the final category is what are the volunteering studies in which people can show compassion for others. Again, I'm reading a conclusion from one of those studies. The 44% reduction in mortality associated with high volunteerism in this study was only slightly smaller than the 49% reduction associated with not smoking. Taken together, these findings strongly suggest that giving support rather than receiving the support accounts for the benefits of social contact. And I said, well, I at first dismissed that whole category of studies because I wasn't even going to include them because, well, that's just easy because we were just self-selecting for people in good health because they're more likely to volunteer. Wouldn't that be so? However, again, when you look more carefully at the people in the studies, the health advantage of volunteering among those in worse health is twice as large as the health advantage among the healthiest Europeans, is the conclusion of one of these studies. And that was a massive study over 30 plus years involving nearly 300,000 participants with close to 1 million observations. So it really didn't matter if you were in good health or not. It seems that in one of life's perfect little ironies, there appears to be substantial evidence to suggest that health-wise, it is in our own self-interest to strive daily to be less self-interest, to be less self-interested, to be more connected, more compassionate with our fellow human beings. These are observation studies. You would say, well, gee, they're not gold standard randomized controlled placebo studies, which of course you couldn't do. You couldn't force some people to volunteer and some people not volunteer. You couldn't force some people to have some friends and other people not to have any friends. So they have to be observational studies. And when people make that objection, I say to them, name for me the study that was the gold standard proving, first you ask yourself, do you believe that smoking is a risk factor for lung cancer? Nearly everybody says, yes, they do. So I would say, what's the name of the study and the authors of the randomized controlled, placebo-controlled, double-blinded study that proved that? And you just can't, nobody can name it because it doesn't exist. The study that proved that association, which was subsequently proved again and again by further studies, was a huge observational study called the British Doctors Study by Dolan Hill, published in 1950. But again, you can't ethically randomize some people to smoke and some people not to smoke. So observational studies have their limitations. And the reason I put all these studies in, because when I found one that showed something surprising like the conclusions I'm mentioning, then I found a second and a third, and sometimes as much as 6 or 8 different studies. The ones with the placebo benefits, I found a good 10 or 12. I've had 5 or 6 mentioned in the book. The volunteering studies, again, another half a dozen or so. So anyway, I think what we need to do as a society is pay more attention to the fact that we are a biopsychosocial species. And not only is the conversion from a healthcare worker-patient relationship important because it feels good, it causes you to live longer, and there's evidence. And I remain hopeful that the process of dollar-driven decision-making by healthcare business interests can be slowed and even reversed if we can reestablish that primacy of patient welfare-based decision-making. I'm fully convinced that it can be done, but I'm far less optimistic that we'll muster the effort societally to confront and alter where we're going right now. And so my ask is for people to, if they can find the time to read my book, that'd be grand. And if you have if as you're reading it, you're thinking BS, 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 Drew, you're missing the mark here, please let me know where you think I missed the mark, or if you've come across other studies that are in support, I would love to learn about those as well. And I'm willing to engage with anybody who finds that an important concept, the idea of preserving the patient-physician relationship. It's really the healthcare worker-patient relationship. It's not just limited to physicians, but the physicians are the primary actors.
Thank you, Drew.